Morena, yeah, can you hear me?
We can. Awesome.
Excellent. Shall I try sharing my screen and see if that works too?
Yes, please. There we go.
How's that, Tank? Can you see that?
We can see it. Yep, you can start. I'll leave the floor
Fire
with you.
away. Fire away. Yeah, great. Hey, thank you, Morena, everyone. Thank you so much for the invitation to come and speak to you. I'm very apologetic that I'm not there in person. I was intended to be. I was all lined up to be. I had flights booked for yesterday morning and also a hike booked in the hills surrounding Ōtautahi with a good friend, Dick Ongley, who's an anaesthetist down there. Um, and I missed out on that too. So I'm bummed out, but we've got COVID in the household and I've been testing negative, but have just woken up with a sore throat. So you know what? It was probably for the best because I can't think of a worse room of people to infect in some sort of super spreader event than a group of cancer nurses because your mahi is so important. And I just want to acknowledge you guys all today and everything that you do because you're a big part of the solution to a lot of the problems that I'm going to talk about this morning. So again, morena koutou ko Jason Gurney tuku ingoa ko ngā pui tuku iwi ko otago whakaihu waka e mahi ana. My name is Jason, and I'm an epidemiologist at the University of Otago. As mentioned, I direct the Cancer and Chronic Conditions, or C3 research group. And I'm also seconded, it's not the Cancer Nurses Agency, it's the Cancer Control Agency, which is Te Aho o Te Kahu, which is our National Cancer Control Agency, which many of you will be aware of. I want to talk to you today about why equity is more than a catchphrase and with a focus, because our work focuses primarily on Māori and cancer. It's going to be a little bit of a rolling journey between sort of telling you a little bit about myself and where I come from and why I got into doing what I'm doing, with a lot of kind of data thrown in to show you, to impress upon you the importance of the context in which we do our research, and then also just to try and come up with some ideas for what perhaps the role that you guys have or the role that we as a system have in trying to address these problems. So as mentioned, and I just want to start by saying thank you to the organisers because it's easy to put an equity-focused talk at the beginning of a day like this when equity is kind of in favour, and it very firmly is not at the moment. Just having the word equity on a slide at the moment is somehow controversial. Which is a new area for us to navigate. Our mahi hasn't changed; it stays the same. The problems stay the same, regardless of divisive leadership. So the things I'm about to tell you are not changing anytime soon, and we need to do something about it. So I will roll on with my talk. So as mentioned, ko. So I work at the University of Otago, and this is our research group, and I'm also at Te Aotearoa as their senior epidemiologist. And I'm also a very proud member of He Ahuru Mōwai, which is Māori Cancer Leadership Aotearoa, which is kind of a group or a network of people working in cancer, Māori working in cancer. So people working in government, people working in universities and community groups and patients and everywhere kind of in between. It's a pretty great network. But much before I got involved in those organisations, I was born and bred up in Whangarei and actually spent a lot of my my kind of formative years in this place right here, which is for those in the audience who are from Te Tai Tokerau, they might recognise this as Maurice's Bay up in Whananaki. And I'm very this is a place that's been in our whānau for generations, and I'm very lucky to say that this is a shot from our batch. So I get up there as often as I can. As you can imagine, I learned how to surf in those waters, how to fish, how to row a boat, all those sorts of things. And this is where I really go to. This is my tūranga waiwai. It's where I go to when I need to kind of fill myself up again. And I know I can always tell if I've been away for too long. I can tell I'm not feeling right on the inside. As soon as I get back there, it's like everything's ticker again. Everything falls back into place. So this is where I grew up. It's a very interesting split of people up there. So especially now, there's a real divide. So you've got the rich people. Like if I was to if you were to look to the left-hand side of the screen, in the corner of the bay there is Hilary Barry's batch. So there's some famous people. Al Brown's got a batch up there, the chef. There's some quite wealthy, well-to-do celebrity type people living up there. A few former MPs, that sort of stuff. And then there's a really very poor rural Māori community that live more in the valley, and they face this sort of significant challenges, that a lot of which I'm going to talk about today. So I kind of grew up with a foot in both camps. So I feel like that brings a little bit of perspective to the work that we do. Just a gross slide alert. So the next slide is a bit gross. When I was at the University of Auckland, which is where I did my studies, and I did a Bachelor of Science and I did my PhD in biomechanics at the University of Auckland, I really started to come to grips with the extent to which health outcomes were patterned by ethnicity, like really strongly patterned by ethnicity. The thing on the left here, for those of you, I'm sure you all know, this is a big nasty foot ulcer, a diabetic foot ulcer under the first metatarsal head. And if you don't treat that ulcer, you get the thing on the right, which is lower limb amputation. So when I was working at the University of Auckland, I became aware of these really strong, how these sorts of things pattern quite strongly by ethnicity. And when I took my first job with Diana Safeti, who's my good friend and very much my mentor, and is now, as many of you know, is the Director General of Health. She took over from Ashley Bloomfield. She hired me into my first job at the beginning of 2000 and end of 2010, and really taught me the ropes about epidemiology. And what Di really taught me was that these really strong, these diseases that really strongly pattern by ethnicity, that it's no accident that happens. That actually we have a very much an uneven playing field in terms of building up the situation within our society where these sorts of really quite horrific disparities in disease outcomes can occur. So I got my I cut my teeth, if you like, with Di in terms of understanding health inequities and the things that really go into driving those. I want to start just to sort of frame ourselves with a quote from Paparangi Reid and Bridget Robson from Hauora 4, which is, it might be, what's that? 2007, 2017, about 17 odd years, if my math's right, 15 to 20 years old, this document. But it still rings completely true. The quote is, "Equity, like fairness, is an ethical concept. It doesn't mean that resources are equally shared. Rather, it acknowledges that sometimes different resourcing is needed in order that different groups enjoy equitable health outcomes." And I'm going to return to this quite a little bit later, because I think we're getting stuck in the weeds at the moment as a society about our kind of understanding and agreeing on this. It's the different resourcing part. It becomes tricky to navigate. So let's come back to it at the end and return to it. There's definitely a recipe for how you build a health inequity. And this is, again, from Paparangi Reid and Bridget Robson, but it builds on the work of Kamara Jones, who some of you might know, but definitely worth jotting that name down. Kamara Jones is kind of the mother of our understanding of the role of institutionalized racism and interpersonal racism, and the role of racism as a driver of health inequities. The first kind of step in the pathway, or the first part of the recipe, is you have to ensure that there are differences between groups in terms of the determinants of health, or an exposure to the things that lead to disease. So you have to make sure that your society has differences between groups in terms of those determinants of health. The second thing you have to do is you have to make sure, once you've set up those differences in exposure to for the determinants of poor health, you then have to make sure you've got differences between groups in terms of access to the healthcare that they'd need to solve those problems that arise from that differential access to the determinants of health. And then the third part of the pathway is, the third step in the pathway to health inequities, you then have to make sure, even if people get to that care, that there's differences between groups in the quality of that care received. And so it might not surprise you that there is evidence along each of these three bits of the pathway where Māori are doing worse than non-Māori. Now, I apologize if you've heard me talk before and you've heard all this stuff, but there are things that I need to tell you to make sure that you understand and that we are sort of on the same playing field and to bring life to the talk today. The first is to understand that there are inequities in the incidence of cancer. So this is when we look at the whole population who is getting cancer, and are Māori more likely to get cancer than non-Māori. I'm going to go into that in detail in a second, but just to spoiler alert, Māori are more likely to get some cancers, not all cancers, but some cancers. And the key here is particularly ones that have a poor prognosis. Then we need to understand that there are inequities in mortality. So this is when we look at the whole population who is dying of cancer. And when we do that, we see that Māori are more likely to die from cancer essentially across the board, although this is really strongly driven by incidence, which we'll get back to in a second. And then the third thing that we have to understand is that there are inequities in survival. So this is when we just look at those people who are diagnosed with cancer. So that's a subgroup of the whole population. When we just look at those diagnosed with cancer, essentially across the board, Māori have poorer survival once diagnosed. So let's step through those one at a time and just give them a little bit more detail. So inequities in incidence. This is the top 10 most common cancers that occur among Māori. And on this slide, I've left off what those cancers are. And the reason is I want you to have a wee guess as to where a given cancer might be. So you might be looking at the top 2, for example, and think about, okay, which cancer is that? Which cancer is the second one, etc. So have a think about where you think, the blue bars are Māori, by the way, the white bars are non-Māori, and this is the age and sex standardized rate. So this is for every 100,000 Māori in the population. If we look at the blue bars, this is how common that cancer is per 100,000 people. So if we look at the top, the most common one, it's looking around 45 per 100,000 for that cancer. So where do you think which cancers do you think these are? You don't have to answer out loud. You can just have an internal conversation with yourself. A little bit of a hint, have a look at the gaps between the blue and the white. So here's the labels. The most common cancer among Māori, even when you pull together males and females, so this is everyone pulled together, is breast cancer. Female breast cancer is still the most common. That's how common breast cancer is, really common cancer. But the second most common cancer, kind of nipping at the heels, is lung cancer. And that was why I said, have a look at that disparity between Māori and non-Māori as your hint. Then we have prostate and colorectal. So this is sort of changing over time in the context, certainly in the context of colorectal cancer, to a lesser extent for prostate cancer, where we have non-Māori. These cancers are traditionally non-Māori cancers, which is a horrible thing to say, but it just meaning non-Māori tend to have the highest incidence rates of those cancers for various reasons, which we won't go into. But colorectal is kind of Māori and non-Māori coming together more or less in terms of incidence rates over time. And it's worth bearing in mind that this data finishes just before 2020. So those more recent changes over time aren't reflected in this data. But then let's look down at those cancers that have that poor prognosis. And in a second, we're going to get to the mortality to have a look at that. Let's look at stomach cancer and liver cancer and look at those disparities in incidence. Look at pancreatic cancer towards the bottom. Very poor outcome cancers, poor prognosis cancers, much more common among Māori. That's what I was talking about at the start, where yes, Māori have higher incidence of some cancers, but it's really, it's by far and away the worst for those cancers that have a poor prognosis. So what's driving that incidence? So let's think about the proximal drivers, because if we were to start thinking about those really broader social determinants, we'd be here all day. Let's think about the proximal drivers. So tobacco is obviously number one, which is why the backtrack on the tobacco smoke-free legislation stuff is so scary. The second is infection. Infection is a really poorly understood and overlooked cause of cancer for Māori. So on the top is the top figure here under that image here under infection is the Helicobacter pylori bacteria, which is probably the most important cause of stomach cancer for Māori, and that's an infection you get usually as a child. Ditto down on the bottom here, this is the hepatitis virus. Hepatitis is the most important cause of liver cancer for Māori, which is why vaccination against Hep B, surveillance once you've been diagnosed with hepatitis for the development of liver cancer, treatment for antivirals for Hep C, those sorts of things. That's why those things are so important to nail, because we need to prevent that subsequent liver disease among our patients. Obesity is also a really important cause of cancer for Māori, so particularly when we think about cancers like uterine cancer and breast cancer as well. Diabetes is an interesting one. So Māori have higher rates of diabetes than Europeans, Pacific even more so. And diabetes kind of works in both directions in terms of as a cause of cancer, because it can both cause cancer and be caused by cancer. So it can kind of split in both directions there. But if you have more diabetes in your population, you can imagine things like pancreatic cancer, which is really strongly related to diabetes. Those rates, that's one of the drivers why Māori would have high rates of that cancer. So that's incidence. That's who gets cancer. Let's roll through mortality just a little bit quicker, because now that you understand that incidence gap, you might be able to get what's happening in this figure pretty quickly. So again, this is who's dying in the population, top 10 most common causes of cancer death among Māori, and you can see those disparities there. Now, I don't think anyone's going to win a chocolate fish today for guessing what that top one is. It's lung cancer, right? So lung cancer, very deadly cancer. Breast cancer, really common, was the most common cancer, but the mortality rate is much lower because the survival from breast cancer is much better than it is for lung cancer. But let's see those other cancers. Look at that: stomach cancer, liver cancer, pancreatic cancer, all those cancers moving up the pile because they are so, the prognosis for those cancers is so poor. So what are the drivers of those mortality inequities? Well, as I mentioned, remember, mortality is when we look at the whole population who's dying of cancer. So the first thing that matters is whether or not your bit of the population has a higher rate or a lower rate of that cancer. Because if you're more likely to have that cancer, you're more likely to die from that cancer. But there's a little bit of an extra cherry on top that's also pulling a lever, which is poor survival. So that is where we need to get into understanding what's happening among those people who are diagnosed from diagnosis forward. So let's look at inequities in survival. This is called a Kaplan-Meier survival curve, which I'm sure many of you would have seen, and it's looking at survival over a 5-year period. The blue bar is Māori and the white bar is non-Māori, and this is lung cancer. So this is focusing in now just on lung cancer, just to show you that disparity. Depending on the cancer, you get a different looking Kaplan-Meier curve, and this is cancer-specific survival. So this is death from lung cancer. Now, the problem with these curves, when you look at them, is that invariably, unless they're age specific, so unless they're like, this is a survival curve for people aged 50 to 69, when you're comparing ethnic groups using these curves, they can be really strongly confounded by age. Let me explain. So Māori have a much younger age structure in their population. The easiest way to understand that is it just basically means there are fewer old Māori than there are old non-Māori, really meaning old European people. What that means is, because being old is a risk factor for dying, believe it or not, that means that if you're comparing Māori and non-Māori, you're not comparing like with like in terms of likelihood of death. Even if you're just looking among lung cancer patients, if you were just to compare the non-Māori patients to the Māori patients, the non-Māori patients would be older. So therefore, this is actually a kind of unfair comparison. We have to do something a little bit more nuanced in order to tease out that real survival difference. And this is what we end up coming up with. So this is the top 24 cancers that occur in our population, right? And again, I've taken the labels off so you don't know which cancers they are. But the blue bars represent what are called hazard ratios. And you probably have seen these before. This is just the extent to which the extent to which the bars push out to the right is the extent to which the survival is worse for Māori. The extent to which that one little bar at the bottom pushes to the left is the extent to which the survival is worse for non-Māori. Now, the hazard ratios means if I was to look at the top here, or maybe even let's look down here, because I can tell you for a second, just a bit of a spoiler, here's lung cancer here, right? In fact, let's just chuck the labels up. Here's lung cancer here. So this means that a hazard ratio of 1.3 or 30% excess mortality, meaning once diagnosed, Māori are 30% more likely to die of their cancer than non-Māori. And this is adjusted for that age confounding. So this is adjusted for age. So it takes that out of the equation. So it's adjusted. This is actually adjusted for age and sex, although sex doesn't make a difference in this context. So remember, this is a relative measure. So it's important to realize that the data on top about melanoma, oh my goodness, Māori are much less likely to survive their melanoma than non-Māori. Yes, except the number of Māori who get diagnosed, or who die from melanoma each year, I could count on one hand, maybe two on a bad year. Whereas if you look down at lung cancer here, there's a 30% disparity, but more than 300 Māori die per year. And I want to show you that in just a second. So this next figure is probably one of my favorites, and I apologize, I know I'm throwing a bunch of data at you, but hopefully a little bit of it lands. All this is exactly what I showed you on this figure, combined with the number of Māori who die of a cancer in a given year. So the further up on the vertical a dot sits, the more people are dying of that cancer. And then the further that dot pushes out to the right-hand side of your screen is the survival disparity. So that's that data there. So it's just an XY coordinate of deaths versus survival disparity. And I want to show you why lung cancer is so important for Māori, because here's lung cancer. So that's the number of Māori who die from lung cancer, and then you've got that 30% disparity. So if you have cancer sitting out to the right over here, those are your priority cancers to solve for Māori, because Māori are dying of them a lot, and you've got some inequity gaps to solve there as well. Just as Jason's little tangent, bearing in mind where that lung cancer dot was sitting, in terms of cancer problems that we need to solve for Māori, lung cancer is priority 1, 2, 3, 4, and 5. The reason I say that is because if you add up the number of Māori who die from lung cancer in a given year, it adds up to the following next 5 cancers combined. Okay, so lung cancer is absolutely priority number 1 in terms of solving for Māori. So what about the drivers of survival inequities? Now, we've got I'm going to say framework alert, because I'm allergic, generally speaking, to frameworks, because we've all seen 6,000 frameworks. But at least the next one at least tries to illustrate in a nutshell our current understanding of what is driving survival inequities. And I promise you very few arrows pointing in different directions, so it's not overly complicated. But here it is. Don't worry about reading the text. Just look at the chunky big stuff. The stuff on, so these are the factors that we understand at the moment are important in terms of driving cancer survival inequities. And that's not just for Māori, it's globally, right? So this is, we are not the only ones who experience not only differences in terms of indigenous populations, but survival disparities between ethnic groups within populations. And this is kind of the current level of understanding of what might be driving those things. Up top, you have quote unquote patient factors, although actually that term's a little bit problematic, because things like the way that comorbidity is patterned and deprivation is patterned is actually really strongly rooted in the social determinants of health. So thinking of those as a patient's fault is actually problematic, because it's not their fault really that they're living in deprivation. Things are kind of hardwired to be that way. I've put purple bars around tumor biology and patient preference because there's competing evidence in both directions as to whether or not these are important factors in driving cancer survival inequities for Māori. So for some cancer, you can imagine for some cancers, there might be some evidence that Māori are more likely to get some type of subtype of cancer that is more aggressive than others. I've heard a lot of people talk of that as being the reason why Māori have poorer outcomes than non-Māori. The problem is the evidence about that is very limited, and it's certainly not cancer-wide. And actually there's evidence in both directions. So for example, Māori are more likely to get both HER2 and triple negative breast cancer, which points in opposite directions in terms of severity. Patient preference is another one. So this is one I hear all the time, which is that Māori aren't surviving because Māori don't rock up to treatment and they refuse treatment. Again, there's evidence in both directions, or there's just no evidence. There's no really strong evidence at all. So there's, for example, as Sarah Hill did a study a few years ago that showed there's no difference between Māori and non-Māori colon cancer patients in terms of the types of treatment they prefer, for example. So this is an area where a lot of thought gets put as to this is why, but the evidence behind it is extremely shaky, if not non-existent. Where I like to spend most of my time, and where I think as a society we should be spending all of our time, is within this health systems factors section. So, because these are the bits, this is the system bits, this is the stuff that we can actually change. So the first one is access to early detection. So that's our screening, that's our access into primary care to get that early detection. The earlier we pick up the cancer, the more likely that cancer is to be cured. That's not the same as saying we need to screen for every cancer, because all screening programs do harm. Some screening programs do good as well. Have you heard that saying? So screening is actually really complex and complicated to get right. The main problem being overdiagnosis. So screening is good in some contexts. We've got a burgeoning lung cancer screening program, which is looking like it's going to be really sharp and great, especially if we design it to work well for Māori. But then also the kind of traditional problems of access to primary care for symptom detection, and then ongoing follow-up into secondary care as well. This is an ongoing area of research, of work, policy work, all those sorts of things to try to bridge the gap for Māori. I want to address one other dogma, which is that Māori have poor survival because Māori don't turn up for early diagnosis. Now, there are some cancers for which Māori are more likely to be diagnosed later, but there's some cancers where Māori aren't more likely to be diagnosed at all later than non-Māori. So that is not a cross-cancer problem. Some cancers, yes. Other cancers, no, not at all. An example is lung cancer, where it kind of goes, it's an unusual one where there's no difference in likelihood of Māori being diagnosed with metastatic disease at diagnosis, but there is a difference in terms of likelihood of being diagnosed with localized disease, which I know sounds like I just said two opposite things. What I mean is Māori, there is no evidence that they're more likely to have metastatic disease, but they're more likely to have just a little bit worse than localized, so somewhere in between that metastatic and that purely localized disease. So it's more nuanced than people have given it credit for in the past. And then we have our 3 A's, which I won't go into a lot of depth with, but we have the availability, affordability, and acceptability of quality treatment. Again, this is not something I made up. This is from the International Agency for Research on Cancer. A lot of people talk about this as being a problem across jurisdictions, not just in New Zealand. So where are you locating your services and making sure that they're available for your people who need them the most? How affordable are those treatments? We have a private-public divide in this country in terms of affordability of quality treatment. The haves have better access to the best care than the have-nots. Universal healthcare we may have, but we certainly have a 2-tier system, and the way that is working isn't necessarily complementary at this point. And then we have acceptability of quality treatment. So this is to do with how we are designing our system to reflect the needs of the people who are actually trying to access it, because we do have a system that's designed to work for the majority, so the minority can fall through the gaps. I want to touch just for a second on the standardization of the cancer pathway, because that underpins kind of all of this stuff. And the best evidence I can point to here to say that standardizing stuff matters is that when we look at survival disparities for breast cancer, they disappear if we only focus on those who come through the breast cancer Aotearoa pathway. So there's no difference between Māori and non-Māori in terms of survival who come through that BSA pathway. The differences happen in other parts of the kind of symptom detection and outcomes pathway. That kind of tells us that when you set up a system like BSA to have checkpoints along the way for hit this mark, hit this mark, hit this mark, hit this mark by such and such a date, and you resource the follow-up to make sure that happens, you can get equity in terms of outcomes. So standardization of the cancer pathway is key. Now, that is not the same as saying we need a cookie-cutter approach to how we achieve that. We can have a standardized, key points process that is designed in a way that it works for the population that it's trying to serve, works for local communities, works for Māori, etc. So I apologize, I promise that's the last framework I'm going to put up, but these are really important things to try and untangle, and it's not straightforward. And anyone who says to you, Anyone who starts a sentence with Māori are more likely to die of cancer because, you can just say, I'll stop you there. This is way more complicated. Trust me, I've been working on this for 15 years. It's really complicated. It's not straightforward. If there were one simple solution, we would have done it by now, I'd hope. So how can this group make a difference? My favorite part, where we talk about a little bit of what I think you guys could do. The first thing is, and I don't know if I need to convince any of you of this, but the first thing to do is to recognize that our Māori patients are different to our non-Māori patients. There might still be some people who are a little bit skeptical about that, maybe have bought into the idea that we're all the same. We kind of aren't. The chances are, and this is based on stats, not just hypothesis, the chances are they probably had to overcome more barriers to see you than your non-Māori patients. They're probably dealing with more than one morbidity, and they'll probably face more barriers to timely diagnosis and treatment than your non-Māori patients. By the way, every single one of these, I can send you citations and references for research that we've done that has shown this. This isn't just me just making it up. For example, the more barriers to see you than your non-Māori patients, let's just pull bronchoscopy access for patients with lung cancer. Māori and non-Māori similarly likely to access bronchoscopy in order to get their diagnosis of lung cancer, right? So that proportion is basically the same. But when you look at how far Māori have to travel to get their bronchoscopy, there's a significant difference. So Māori are having to do more to get that same level of care. And in the context of bronchoscopy, they're doing it. They're making it happen, right? So chances are, had to overcome more barriers, probably dealing with more than one morbidity. Māori more likely to have comorbidity. Remember, I talked about those kind of social determinancy type reasons, and we can talk about that till the cows come home as to what's driving that, because it's complicated in and of itself. And then also more likely to face barriers to timely diagnosis and treatment. So your Māori patients are different to your non-Māori patients in some quite fundamental ways, probably. Second thing is to recognize our system wasn't really designed to work for Māori. Navigating health services is more intuitive to Pākehā because we have a largely European-based system. If you look at the way our system is structured and organized, it really kind of reflects what we see in Europe. That's the fault of the system, not the fault of our Māori patients. There is zero value or accuracy, by the way, in blaming Māori for their own poor cancer outcomes. One of the first terms that Di taught me when I started working with her was the term victim blaming. It's really, there is zero value in blaming Māori for the fact that they have the cancer outcomes that they have, or that we have the cancer outcomes we have. The last thing is to make sure that you are strong advocates for your Māori patients, and you're kind of going the extra mile. I know that that's hard sometimes, and I know that it's complicated, and I know that it's tricky, but because of, if we're really serious about solving these problems, we need to come back to what Papangi Reid and Bridget Robson said, which is that sometimes different resourcing is needed in order that different groups enjoy equitable health outcomes. And by the way, I want to come down to this different resourcing bit, because saying different resourcing isn't racist. Saying that Māori need different resourcing to achieve the same outcomes as European is not racist. It's an example of us taking action in the face of need. So that brings me to our next question, which is how do we fight for equity in the current environment? And this is what I want to kind of finish with. The current environment is sort of forcing a shift in the health system focus away from equity towards needs-based. If you guys heard of this, you've probably seen this, and maybe afterwards, after this conference, you might want to Google the needs-based service provision cabinet circular, which has essentially gone to cabinet, which essentially puts this in kind of ironclad language, and it's going to really influence how the system operates, certainly in this government. Now, we can talk about the problems with this needs-based approach all day, and I'll give a few quick ones, a few quick reasons, a few quick problems with this approach. The first is that it ignores ethnicity as an independent social determinant of health, so it completely whitewashes our history of colonization in this country and the way that our system has been set up to disadvantage Māori. So it ignores the fact that it's possible that being Māori and all the things that that carries is an independent determinant of your health, which it is, and we've shown that repeatedly in some of our research. It assumes, as I mentioned in the past, that we're the same when we're not. There are systematic differences between us in some ways. That doesn't mean we don't love each other and we're not a great country and we can't all get along. That's not what that means. It just, we are not all the same. We're not the same people. It's easy to think that we're all the same when you're living in the majority population. It also has a chilling effect. So this idea of moving to a needs-based and away from equity and talking about ethnicity-related things makes people scared to report data by ethnicity or to deliberately focus only on Māori. It has that chilling effect, which is why I started my talk by saying thank you for having me to talk about equity, because it's not cool right now. This chilling effect we really have to push against and resist. And then the missed opportunities. Ethnicity is an exceptional proxy for a whole bunch of underlying things that we can't measure properly or well. So just by focusing on someone's ethnicity, measuring their ethnicity and trying to improve things and having it as a meaningful data element within our research and within prioritization of services and those sorts of things, it represents a whole bunch of underlying stuff that happens in society that we can't measure very well, like the interaction between poverty, housing, education, those sorts of things. So we're missing opportunities by not using this wonderful proxy for so many of those things. The other thing is that, so again, we can talk about the problems of the approach today. I was going to flick through those and then I found myself I had to give a tirade. But we also have to realize that it is what it is. So we have to work with what we have. The government has put out the GPS, which is the government policy statement on health, which is really what they're going to use as the blueprint. This is what we're going to do. So the GPS pushes focus toward faster cancer treatment, which is kind of, if that rings a bell for those of you who've been in the system for long enough, yes, it's the same-ish kind of thing as previously. Reduce times to FSA, so first specialist appointment, reducing times to getting into the system from beyond that primary to that secondary care scenario. Shorter waiting times to treatment. And improved immunization rates in children. And I know that doesn't seem like it's relevant to us right now, but if we're thinking in terms of whānau order, let's think about what we showed before in terms of liver cancer rates. And what we could be doing to prevent that. You know, we should have 0 cases of Hep B related liver cancer in the future. We have the power to eradicate that as a source of liver cancer. And I guess the question that I have for you is, which bits of these could you influence on behalf of your Māori patients? So which bits of this, because we know that Māori are probably going to do worse at most of these things, which bits when you're in your everyday kind of work, but also when you're thinking of us as a society, what opportunities sit here to make things better for Māori? Because just even that immunisation one is a really fantastic one. I've written, I promise I'm about a minute away from finishing. I've written, this never used to have a question mark. So tū manako means hope in Māori, among other things, but conceptually it relates closest to hope. It never used to have a question mark, but it does now. Back in 2019, and some of you might have been there, we ran a conference at the beginning of the year called Cancer Care at Crossroads. And I was very proud to be involved in that, and Di, who's in the middle of this photo, was really essential. Ashley's standing right behind her. It's amazing to think that just in a few short years she would swap and look how he looks much, he looks pretty happy there. I think within about a year he was up to his ears in COVID. This was a really important conference. Out of the back of this conference, we got our cancer action plan, and we also got a cancer agency, Te Aotearoa. Within our cancer action plan, we even got a part of it which said, hey, we're going to try to achieve cancer survival equity for Māori by 2030. That's in our national cancer action plan. That's pretty cool. We wrote a paper about how you might do that, which you're welcome to go and get. Superbly written paper, as you can imagine. But this was pretty cool to have this. This was now 4 years ago, but it's still there. it's there for us to kind of absorb and use as leverage to take action in this area. The Cancer Action Plan is currently being updated by Te Aotearoa, so kind of refreshed, very honest accounts of where have we done well, where haven't we done well. The reason I bring this photo up, this is some of my colleagues from Hauhudu Mowai, but the guy in the middle, who unfortunately has his eyes partially closed, is Rami Rahal. Rami is the new chief executive. So Te Aotearoa was the first chief executive, was Dai Safety, and Rami is the new chief executive now that Dai's the director general. Rami is from the Canadian Partnership Against Cancer. So he's a Canadian, a Lebanese Canadian via lots of different places, an extremely smart, clever, equity-focused guy who is providing really fantastic leadership over at Te Aotearoa and is very open to thinking about how we can influence equity for Māori, and has the ear of the minister, has the ear of Dai, obviously as Director General. So a very important person right now in the context of making improvements and making inroads into solving these problems for Māori. I don't want to finish with a sad bit, but we did have this health and disability system review, and we out of the back of that we got Te Whai Order, which is Māori Health Authority, which was for the first time going to give us an opportunity to start tackling these things in a Māori way. So we had relied on the system as it was to do that for long enough, and the idea was, hey, let's take the bull by the horns and Māori actually have the opportunity to commission services. Te Whai Order doesn't exist anymore. It was given 18-ish months to succeed, which it's not the first time that a Māori-led government-resourced agency has been given far too short a time to succeed before it was let go. But I do want to finish with a little bit of tūmanako, which forget the what is equity title, that shouldn't be there. But I love this quote from Martin Luther King because it does kind of give hope in an area where it really is easy to feel not hopeful at the moment in the context of working on equity, which is when our days become dreary with low hovering clouds of despair, and when our nights become darker than 1,000 midnights. Let us realize that the arc of the moral universe is long, but it bends toward justice. And I do believe that as a society, we love fairness, we love doing the right thing, and that over time, our arc is bending towards justice. So ngā mahi nui kia koutou. Thank you so much. I want to acknowledge Te Aotearoa and the HRC, who the HRC was funding equity-focused research since way before it was cool. And of course, Otago Whaki Waka as well. I'm very happy to take any questions if there's any more time. Kia ora.
Thanks, Jason. That was some eye-opening research and talk that's going on there. So thanks very much. Is there any questions in the audience for Jason? No, we are all good, Jason. Thank you very much.
No problem.
Thank you for taking the time to come and speak to us. And we wish that everybody's well in your household very soon.
Great. Thank you very much. And good luck for the conference team. Kia ora.
Hey.